particularly strongly, versus this pattern here known as the closing pattern, which is a high velocity continuous shunt, which is very often associated with a PDA that closes. So there's some information we could gain from using flow patterns as to what might happen to the PDA as well. Mentioned direction. I've already taken you through left to right is above the line, right to left below the line. So we can characterise ducts as being left to right, bidirectional, or right to left. And this may be of clinical use to us when we're trying to understand, for example, hypoxia or increased oxygen requirement in a patient. What about the hemodynamic importance? So this is now looking at the flow in the descending aorta below where the ductus is coming off the aorta. And so the Doppler pulse probe is down here. This is the aorta coming around. This is the normal pattern here with forward flow in systole and some forward flow in diastole. Very often when we have a large PDA with a significant systemic pulmonary shunt, this is what we'll see, a reduction in the systolic blood flow, so less blood going in systole, and we'll see reversal of flow in diastole. So this is blood now moving back into the lungs during diastole because of the large PDA. And so one of the questions is this a problem for gut and kidney perfusion? It's a visual thing that you see. You may also see this in the cerebral vessels. So the vessels on either side of the ductus arteriosus can be affected by a large PDA. So that's the PDA. So a lot of information, and when we do the talk on PDA, we can talk a little bit more about how we might utilise some of this cardiovascular information from ultrasound to help us make decisions. Cardiovascular adequacy, so the left ventricular output, right ventricular output, measuring other ways of measuring systemic blood flow. We've already talked a little bit about whether it might help us, if we understand the cardiac output, it might help us understand how to treat hypertension or whether we should treat hypertension. Ventricular dysfunction, particularly in the asphyxiated infant or the very preterm infant with an immature myocardium. The need for an inotrope and inotrope choice. So this is a long axis view of the heart now, so we're looking at the heart in this direction along the long axis, and we are here, we're interested in the left ventricular output. So this is the aorta, the aortic valve. If we measure the diameter here and assume a cylinder, we can then obtain the cross-sectional area of this vessel. And the other part we need to measure, non-invasive Doppler cardiac output, is this. This is the velocity time signal from the blood passing through the aorta. So on this axis is time, on this axis is velocity. And this is telling us, using Doppler ultrasound, and I haven't got time in this talk to go through all the principles of Doppler, essentially lets you look at the velocity of red blood cells. And this is the velocity with time as a systolic impulse occurs. And from that, these two bits of information, the cross-sectional area and the area under this velocity time complex, called the VTI, velocity time integral, we can calculate the cardiac output. So the stroke volume will be the velocity time integral multiplied by, that's the formula for cross-sectional area. Once you've got the diameter, you can work out cross-sectional area. The cardiac output will be the stroke volume multiplied by the heart rate. And the cardiac index, which is important with our variable sized babies, is going to be corrected using the birth weight. So this is, the cardiac index is what's usually quoted as the cardiac output, and you can specify it as the left ventricular output or right ventricular output. We can do the same on the right side. So this is now a close-up of the pulmonary valve, the right ventricle's up here, pulmonary artery, and we can measure the diameter across here and get the cross-sectional area. We can take the velocity time integral, and again we can calculate stroke volume, cardiac output, cardiac index on the right side. So this is a schematic of the heart, left atrium, left ventricle, right ventricle, and it's showing us where we're measuring left ventricular output, where we're measuring right ventricular output. In the fetus or the neonate, early neonate, we have two extra things in the heart, the foramen ovale, which is often left to right, and the ductus, which is usually left to right. So if we're measuring blood flow here at this point, there's two contributors to that. The first contributor is blood that's going to go to the body, the systemic blood flow. That's what we're particularly interested in. But also what's coming past this point, some of that is going to go through the ductus arteriosus. So the left ventricular output in a neonate, and this is unique to the neonate, actually is not the systemic blood flow. It's the systemic blood flow plus what's destined to pass through the PDA. And the bigger the PDA, the bigger that amount of blood is. So it's possible that 2/3 of the blood might go through the ductus and only 1/3 goes to the body. So a baby who's got a cardiac output on the left of 300 mils per kilo per minute may only have a systemic blood flow of 100 mils per kilo per minute, like the baby we were just discussing. On the right side, not so much affected. There's less blood coming across the foramen ovale in terms of total amount, but it still will contaminate or increase the right ventricular output falsely as well, or alternatively, if it's bidirectional or right to left, there may actually be blood taken away. So again, we miss out on knowing what the systemic blood flow is. So RV equals systemic blood flow plus what's ever happening at the PFO. So neither the LVO or the RVO completely tell us the full story about systemic blood flow. And that's why we've looked at other ways of trying to assess this. The superior vena cava flow is one of the things we've described, which is blood. It's not all the blood, but it's part of the blood coming back to the right atrium. But it is an important part of the blood. It's the blood returning from the brain and the upper body. And a large proportion of that is brain return. And Gorm and I always have a discussion about this, so we'll talk a little bit. We're just talking about SVC flow, but I'm flagging that Gorm will jump in at any point. So.
No, we are just discussing it here, so I think perhaps we should spend some time in discussing this. I mean the techniques of measurement, because there's the literature there, which is looks very nice. So.
So should we flag that till I finish, move through the talk, and then that could be one of the points of discussion, or would you like to discuss it now?
You decide.
People think of listening to me yet? Finish the talk, let's get started. So we'll finish the talk and then we'll have discussion. But I think it is important to talk about techniques of measurement, intra and inter-observer variation, and the usefulness of this. The bottom line, which is what I always say back to Gorm, is that we have used this technique and associated with short-term and long-term adverse effects. But even in my unit, it's not something that I would do routinely every single day. So, because it is a complex measurement. But the principle is what I'm really describing at the moment. Measurement, we can get a diameter of the SVC, we can get the velocity time integral, just like we can in an artery. There are some assumptions here because this is not laminar flow, and particularly the VTI assumes laminar flow. So, just moving away now from the specifics of the measures and talking a little bit about the relationship between blood pressure and measures of cardiac output, and others have shown this disconnect between the two. So if we draw a line here at what some people may call, I mean, we could argue about this, but just let's arbitrarily divide babies into low blood pressure less than 30, high blood pressure more than 30, and we're also dividing them into low blood flow and normal blood flow. So this divides this into 4 different groups of babies. So tell me about this group of babies here. What's going on with this group of babies? They've got low blood pressure, if we use 30 as the cut-off point, but you could use something a bit lower than that, but normal cardiac output. They're like the baby we presented at the beginning. So the question comes up is, even though they've got low blood pressure and may meet criteria for treatment, if they've got normal cardiac output, do we need to treat them? And this group of babies, these are potentially more concerning babies from my point of view, in that these are babies who, if you're using blood pressure to monitor them, will have a normal blood pressure, but in fact have low cardiac output. So a bit like Isfan's case, a baby who's potentially in compensated shock, and in time may demonstrate signs of that. Is this an early warning sign? If we measure the cardiac output, we can actually start to work out which group our baby fits into. And this is a diagrammatic which Kurt de Waal, one of the people I work with in Sydney, put together just to try and demonstrate the changes that are occurring in cardiac output and blood pressure in our neonates. And it's interesting because there seems to be a specific period of time, somewhere around 24 hours, maybe 48 hours, where babies have a relatively high systemic vascular resistance. and then vascular resistance seems to change a little, and that might just be related to the sudden removal of the low resistance placenta, for example. But this is what, and babies behave in different ways, so the healthy newborn tends to have a day-by-day increase in the blood pressure, and that's the normal pattern if you look at population norms. And if anything, with the increased vascular resistance and a healthy myocardium, which is good at transitioning, well, actually their cardiac output will go up a little to begin with, and then settle out back to normal. Whilst if we look at the immature baby, the very premature infant, or the sick newborn, this is often what we see. A drop in the blood pressure in the first 12 to 24 hours, a drop in the systemic blood flow. So this is a different pattern, and it may take this baby down into measures of cardiac output which are potentially in the dangerous range, in the range where we're not getting decent oxygen delivery to the tissues. And understanding the different types of babies, so a baby who's got high cardiac output, low blood pressure, may benefit more from vasoconstriction. A baby who's got poor myocardial function, low cardiac output, and is vasodilated, may need a different inotrope. So we've got different choices: low dose, high dose dopamine, dobutamine. They all affect blood pressure, cardiac output, and systemic vascular resistance in different ways. And understanding two parts of the equation, the cardiac output and the blood pressure, that gives us an assumption about vascular resistance, which may then affect the way we choose our inotropes. And there are differences clinically. This is one of our studies looking at the relationship, the use of dobutamine or dopamine first for babies with low blood pressure. You can see that on this side we're looking at the change in mean blood pressure. Dobutamine didn't have a big effect on increasing the blood pressure. It tended to increase it, but not by a large amount. Dopamine, very good at increasing blood pressure because it vasoconstricts. But then if we look at the other part of the equation, cardiac output, it's a different story. Dobutamine is good at putting up the cardiac output, and this is a particular group of babies, very preterm babies, in the first 24 hours of life. I'm not talking about older babies. Dobutamine increases the cardiac output, presumably because there's myocardial dysfunction there as well, whilst dopamine can, if anything, some babies decrease the cardiac output because the myocardium is not good at dealing with vasoconstriction and afterload in the first 24 hours. Filling and contractility, hypovolemia, hypervolemia, systemic vein distensibility, visual assessment of contractility, and then looking at M-mode measures. So we've got a range of measures here that are to try and quantify our contractility. So this is just giving you an idea of what we can see. This is the liver here, the atria here. And looking at the veins in the liver, the IVC, the SVC, we can often get an idea about how big those veins are. And a baby who is overloaded, those veins will be wide open and not moving very much. Baby who's hypovolemic, often these veins will be easily, they won't distend and they will actually loosen in the respiratory cycle, so they collapse. So we can get an idea of filling. We can get an idea of contractility, and this is just a visual assessment. I think you'd probably see that this baby here, same baby, before and after treatment, before treatment, after treatment. See the contractility and movement of the ventricle versus this baby. So there's often a visual assessment of contractility helps us understand that there's myocardial impairment. And we can quantitate this. This is using M mode, so this is a line drawn across the right ventricle, the septum and the left ventricle. So we can see the movement of the right ventricular wall, the movement of the septum, the movement of the left ventricular wall as we go through systole and diastole. And we can then look at the diameter of the ventricle in diastole, the diameter of the ventricle in systole, and from that we can determine fractional shortening. So that's how much the ventricle is contracting between systole and diastole. And we can look at ejection fraction, which is simply all of those things cubed. I won't talk about this, it's a little bit more sophisticated, but also looking at the movement of the ventricle. And this is just using the insertion point of the tricuspid valve to look at the movement. Tells us a little bit about right ventricular function. And this is an example of some of the newer measures that are coming in. Understanding pulmonary hypertension. So I've already referred a little bit to this, but measurement of pulmonary pressures using the TI jet, pulmonary outflow tract, waveforms, the ductal shunt velocity, understanding right ventricular dysfunction. Has this baby got persistent fetal circulation? I'll be talking about pulmonary hypertension this afternoon, so I'll talk more about these measures. but understanding the difference between raised pulmonary pressures and persistent fetal circulation, because both of them are part of the syndrome of pulmonary hypertension, but not all babies will have both of those. And the question about targeting treatment comes up here in pulmonary hypertension as well, and the fact that we may not even need to treat some babies. So this is the tricuspid valve, right ventricle. This is a tricuspid incompetence jet. So it's, again, stands out when it's present. And we can then measure the velocity of the tricuspid incompetence jet, and we can use that, using the Bernoulli equation, 4V squared, gives us the pressure difference from a velocity. So if this baby's velocity is 2 metres per second, then the pressure difference across that valve is 16 millimetres of mercury. If it's 3 metres per second, the pressure is 36. If it's 4 metres per second, the pressure is 64. So each of those is telling you about the pulmonary pressure. So clearly 64 is probably suprasystemic. So if this is 4 metres per second, likely to have suprasystemic pulmonary pressure. I'll talk about this later on this afternoon. This is looking at the shape of the right ventricular waveform. And we'll discuss that further in the pulmonary hypertension talk. Other uses: screen and early diagnosis of structural heart disease, management of sepsis. Babies, that's a little bit later on. When a baby becomes septic, the same thing, the vascular resistance often changes, and we can judge how much volume we need to give in these babies sometimes. Monitoring the asphyxiated infant. This is a group of infants who I think we often neglect from a cardiovascular point of view. If the blood pressure is satisfactory, we accept that their cardiac output is normal. Often they have low cardiac output, which is unrecognised. Line position and malposition, intrathoracic pathology, pleural effusions, pericardial effusions. There's a couple of babies in Australia whose lives have been saved by the fact that there was a neonatologist and an ultrasound machine in the unit at the time they had an acute cardiovascular collapse. People were able to realise it was a pericardial effusion, drain the effusion. What about this? This is the CPU on a baby who we were about to put onto high-frequency ventilation, INO, because the baby was desaturated. We couldn't get the saturation up. It's a single view. It took us 5 seconds to take this view. I'm not trying to simplify echocardiography, but I'm just saying this is. So we've got parallel outflow tracks. This is the right ventricle, left ventricle. We've got both outflow tracks in the same view, which, if we look at a normal on this side, this is what we normally see. We see the right ventricular pulmonary artery coming across the top of the aorta, as compared to this. So this is a baby who was diagnosed with having transposition before the clinical decision to ventilate the baby and likely cause problems with the lungs and all the things that come with ventilating a baby who's got normal lungs, who you think has got a problem with pulmonary hypertension. Here we made that diagnosis at 1 hour of age. So structural heart disease, as I mentioned, is often a secondary thing that we find because we are doing ultrasound for other purposes. We may find a structural heart disease. Equally, some of the measurements we do, it's important to know that we have normal structure, because you can't measure the right ventricular output in a baby who's got an abnormal pulmonary valve. So we do need to know something about structure, and part of the training program is safe structural screening. The point is that quite often babies are referred earlier in our unit now with structural heart disease because we come across that because we're doing an ultrasound for a sick baby and then we realise it's a cardiac baby, rather than doing all the treatments and then coming back to cardiac. So I've mentioned sepsis. There's some evidence to say that babies who are going to do badly in sepsis have low cardiac outputs early on. I've mentioned asphyxia. Again, there's babies who have left ventricular dysfunction, more likely to develop a severe encephalopathy than babies without left ventricular dysfunction. So it may be useful to know about our baby's cardiac function when they're asphyxiated. And we'll come across other things like catheters through the foramen ovale, pig lines in too far, etc. And another use, when to wean or cease cardiovascular therapy. I've mentioned ductus arteriosus already, the limitation of exposure to non-steroidal. So if a baby's duct is closed after 1 dose of non-steroidal, should we keep treating? Volume, we've mentioned a little bit, trying to avoid fluid overload. When to wean inotropes. This is a particularly important area, I think, which we'll discuss this afternoon, is when to wean our inotropes and our INO. We're moving from a baby who's had cardiovascular lability to a baby who's now got a respiratory problem quite often. And if the heart is normalised, that's a signal to start weaning out cardiovascular supports. So that's CPU. You've seen the range of things we can do. It's a focused examination at the bedside, real-time, serial, function mainly, understand physiology, refine our clinical decisions, target treatment. There's a range of things we can do. It's not just echocardiography. So I'm going to get over time. I've got a little bit about training and accreditation. 5 more minutes. So we'll just talk a little bit about training, accreditation, and audit and usefulness of CPU. Clearly, there's a range, a need for training and accreditation to legitimise current use. So we want to make sure that people who are using it have some idea of the limitations of ultrasound and the techniques. That will allow standardisation, and importantly, training programs will also enable access to supervised training. Credentialing starts to come up, so there's certainly a push in our country towards credentialing what a neonatologist can do based on their training and skills. And so if we have a training program, we can credential ultrasound, issue quality assurance and maintenance of skills. This is a recent article on point-of-care ultrasonography from the New England Journal last year. These are all of the specialties now who are using ultrasound to guide them at the bedside. And interesting, neonatology is mentioned, but not for any of the things that I've discussed. So a little bit of a misunderstanding of what's available. It's cranial and pulmonary assessment, but no mention of cardiac. Function echo is available across countries, and there's different models in many different countries. In France and New Zealand, it's a common skill in neonatology, and the cardiologists are actively involved in training and getting people to learn because it helps them in their role. In America and North America and Canada, there's been restriction on use and cardiology-based model of training for many years. The UK, widespread use. Australia, initial concerns, but we now have a good collaboration with our paediatric cardiologists. Just a brief word on this, the approaches now to training. This is Isfan and Shahab have both been involved in the first step towards training in ultrasound for North America, Canada, and this is also for Europe. So there are some Europeans mentioned on this. The term targeted neonatal echo was used, so we've talked about terminology, whether that's the best term, but that's the term that's was best used in their setting. And basically, great first step, and we will congratulate Isfan and Shahab and the others on that about moving forward and getting it recognised that neonatologists might want to train in ultrasound. But there are some issues with these guidelines, and we haven't got time to talk about all of them. But basically, any program needs to be relevant to neonatology. So, is it appropriate to focus on structural heart disease when such a small percentage of our scans are structural heart disease? It's clearly important to have a component of structural heart disease. Should that be the main focus? Age-appropriate training. Some of the training recommended in the guidelines is in the echo lab with older children with abnormal hearts. Again, questioning the usefulness of that for neonatologists. The question about physiological functional uses. So there are many uses beyond the standard ones that cardiologists now use, and I've covered some of those. They should be included in our training programs, and in fact, neonatologists are often the ones with this knowledge, and particularly the knowledge to translate what we're seeing in the measurements into the clinical field. So we need to spend some time training under neonatologists. The other question is, are they achievable? So in terms of time commitment and access to training, because people can't always afford to take 4 to 6 months off their training and go and work in an echo lab, which is the primary part of the guidelines as they stand now from the consensus group. So I think we've covered the difference here between echocardiography and CPU, and I think when we're looking at training guidelines, this difference is important. We don't want to focus on this echocardiography side of the spectrum and miss out on the CPU side, because that's what we are really using it for, not for this. So this is a small component of the guideline. So the barriers to implementation of ultrasound may be financial. So sometimes the introduction of neonatologists picking up an ultrasound probe is perceived as there will be a change in revenue streams for cardiologists. I can tell you absolutely in Australia that's not been the case. Our cardiologists are busier than ever because we're finding things that we're not sure about, that we're asking them to see. And they're not coming in